Hello, it's a pleasure to be here, and I want to thank very much the Sao Paulo State Society of Anesthesiology for this very kind invitation to the Symposium Internacional of the SAES. Very thankful to Gustavo, my friend, who gave me this invitation to present you about the SAFEST project and what patient safety improvement opportunity it is, the project that we are running since 3 years. My name is Daniel Arnal. I am an anesthesiologist, head of the surgical process at Hospital Universitario Fundacional Corcón, and also a member and past chair of different organizations in patient safety, the Spanish Incident Reporting System, and the Patient Safety and Quality Committee of the European Society, the SAIC. And right now, one of the researchers in this project. So I'm going to talk about this in extent. So this is the SAFEST, which calls for improving quality and patient safety in surgical care through standardization and harmonization of preoperative care in Europe. It's a European Union funded project with more than almost 5 million euros that we've been working with different partners throughout Europe, as you can see, from Estonia to Portugal, going through Germany, Czech Republic, Netherlands, Belgium, and Spain. The SAFEST objective is to improve the adherence to evidence-based preoperative patient safety recommendations by 50% and reduce the frequency of surgical complications by 8% after 18 months of intervention. This project is meant to run from 1st June 2022 and will finish 30th May 2026. And the project is available in this publication, the project study protocol. Apart from the 10 partners, we have 5 countries participating with 10 hospitals, 2 hospitals in every country with 5 country coordinators. We have a scientific expert group, a scientific advisory group that was formed by European representatives from all stakeholders in the surgical process, surgeons, anesthesiologists, nurses, but also quality and experts, patients, and so on. A European patient group, patient representatives, and local patient groups in every hospital at the hospital level, with participation of the patients in the 10 hospitals that are working, and an external advisory board with 3 experts. The 10 hospitals that have been working in the piloting this project are 10 hospitals from the Netherlands, Portugal, Spain, Estonia, and the Czech Republic. And these were the phases of the project. We started working on consensus of the recommendations on preoperative patient safety. Then we built up a guided self-evaluation platform and structure. We performed work in prioritization following the self-evaluation, and we are working on a quality improvement collaborative process to improve safety in these hospitals. And we'll follow a post-implementation, post-collaborative guided self-evaluation, and then an evaluation and escalation of the project. The whole process, as you may have understood from all the patients' participation in the project, with a very important part of patient empowerment. And the phase we are starting right now, already as we are facing the last year of the SAFEST, is the escalation of this project. And this is why we want to make this open call to take part of this escalation that can be from hospitals in Europe, but also hospitals beyond. And Brazilian hospitals are invited to participate as well. So looking to these phases on the project, I'm going to start explaining not the whole project because it would take a couple of hours, but the main areas so that we can understand how do we get to the phase we are running. So we started with the recommendation consensus. To get to it, we performed a systematic review of clinical practice guidelines looking for any kind of perioperative patient safety recommendation. We screened more than we screened more than 4,000 records and found more than 4,600 recommendations following these recommendations. Finally, using 267 clinical practice guidelines, and we did find 78 recommendations that combined high quality of the clinical practice guideline, strong recommendation, and normalized, so say, a level of evidence. With this in mind and a process of synthesis, we work into a consensus on them. It was not just taking what is in the literature, but using what is being used in the literature. We gathered the scientific expert group and the scientific advisory group that we had. We focused on those recommendations with strong high agreement on our strong recommendation. We performed the quality assessment. We worked on the synthesis of taking out duplicates and prioritization, and we presented to this advisory 99 recommendations. We ran a Delphi survey of 2 rounds and a final consensus conference. This is the picture of that consensus conference. And came up with, at the end, 101 recommendations. And we said, how can we depict these recommendations? Because when we have them, a list of them with a proper explanation, but it is a long one. But we run into what we call the patient safety, the safest patient safety compass. We have the 101 recommendations presented in this kind of compass that we can go through it. We can check on the different recommendations and then make a self-evaluation to then decide where are we going to start working on them, what would be the prioritization. And we could have like one hospital deciding having a prioritization of these recommendations. I'm not going to go deep into them because we don't have much time on it. Or we could have this other hospital that could be quite similar to the first one because in a similar area or conditions. Or we could have other hospitals that decide differently, different recommendations. This is something that can be performed hospital by hospital, deciding what is the situation. The self-evaluation process is performed through Safest platform available online. We have the 101 recommended practices that were translated into 104 standards and then measured through 154 measure elements. These measure elements can be worked out individually and score them between 0 and 10 to decide whether we have not started working on that, we have them partially implemented, we have them fully implemented, and we can record the evidence available for it. And at the end, we can have different outputs to see what is the situation of my hospital in comparison with the self-evaluation of other hospitals. This is not meant to compare the hospital as such, but to give us an idea what are the areas where we can work a bit more strongly. Then we can go one by one, checking on every single area of the standards that are linked to the recommendations built up through the consensus. So working on this, we made for the safest project a work on prioritization. We started working between the 10 hospitals together with the research team to set areas of common improvement in the 10 hospitals, areas where every hospital, or at least the most of the hospitals, would have some opportunity for improvement. At the end, we came up with improving the perioperative evaluation and optimization and safe discharge along the surgical entire pathway. So we started working on different areas through the continuous of care, especially for patients with cardiovascular disease, obesity, diabetes, patients with sleep breathing disorder, risk of delirium, frailty. From the beginning, from the perioperative assessment to the rehabilitation and optimization before surgery, intraoperative management of these high-risk patients, inpatient improvement of the inpatient follow-up, safe discharge involving the patients, and postoperative rehabilitation. All this came up with different areas that the different hospitals have been implementing depending of their situations, like using validated risk scales for the perioperative assessment, increasing the rehabilitation and optimization from ERAS programs and primary care involvement in the optimization of the patients for preoperatively. Using areas of improvement intraoperatively, ward detection monitoring of patients that may deteriorate in the postoperative period, and so on, medication conciliation. All along the project, there have been many actions in the 10 hospitals. The expected results from the safest are that have been already, some of them published, as I mentioned for the recommendations, is the core outcome sets for patient safety in perioperative care, because we are now checking on the perioperative results and outcomes from these hospitals, and there has been one work package working specifically on a core outcome sets. The guidelines for patient safety care in surgical care for patient safety, patient-centered and patient safety, that are these recommendations. We have created lay language materials for patients, and we continue creating lay materials for patients, training materials for the different hospitals, the online benchmarking and self-evaluation platform. We are building an international collaborative network, and at the end it is like a toolbox of perioperative safety and training materials, together with a work on the evaluation of the patient safety. So the safest approach has always been, as I mentioned, patient-centered and evidence-based. We work on the recommendations based on the evidence, and we work hand by hand with the patients since the beginning. It's a collaborative. We have been collaborating with so many stakeholders in the perioperative period, not just anesthesiologists, not just surgeons, not just nurses, but all together, and together with other specialists and the industry and patients and even decision makers. It is scalable, and it can be adapted to the local circumstances and situations. So this about the scalability is what now we can present to the world, and I'm happy to bring here to the Sao Paulo State Society of Anesthesiology. Because we have an open call to participate in the Safest. You can dive into the Safest project website, which is safestsurgery.eu, and there you can find an interest form, an area where we are aiming to have a guided self-evaluation and implementation materials extended to more than 100 hospitals in Europe and beyond, and Brazilian hospitals are invited to this as well. You can use this QR code to log into the interest form, where you can, I will explain what is the process to be involved in this project, and I really invite you to think of it. The core principles of the self-evaluation is to identify the improvement areas. We want to focus on this self-evaluation to detect the areas of improvement. We want to strengthen the patient safety culture to foster patient safety in every aspect of the perioperative period, started from before the hospital and ending also when the patient is fully recovered after hospital as well, not only during the hospital period. It's built on trust and transparency. Nobody is going to check if you are doing a self-evaluation, trying to trick the self-evaluation. There is no need, there is no reason to do that. This is based on trust on the different hospitals that they are aiming to improve patient safety. Because there are no rankings, no competition, hospitals will always remain anonymous between them. We will always only be able to compare our self-evaluation with our colleagues' self-evaluation from the area, from similar hospitals, or to the global number of hospitals, which doesn't really mean that you are competing with anybody. It's just to check if we see ourselves similarly to how others see themselves. Because this is a self-diagnosis, it's not an accreditation. We will have some kind of diploma, as I will say later on, but it's not a formal accreditation or certification. But we want to enable some kind of benchmarking for mutual learning. That is what it means when we compare with how are the others anonymously to the other hospitals. So the benefits and contribution of the self-evaluation is that you will assess patient safety practices in your perioperative care. You will receive personalized feedback and expert recommendations. You will be able to do some benchmark with against other hospitals across Europe and across Brazil and across Latin America and so on. You will be able to contribute setting new safety benchmarks in healthcare, because you will be part of this network that we will work together, and in the process we will learn. You will learn with us, we will learn with you, and it will be, we will create safer surgical environments. For example, about patient safety practices, this is one of them. Our hospital using evidence-based systems to identify high-risk surgical patients for further perioperative assessment, or other is are risk factors being addressed in primary care before surgery. This depends on the local circumstances, the local health systems, and things like that. But there are some ideas of what are the questions that we may face. So what will you receive if you get into the Safest project? You will have full access to the Safest platform. That is a dedicated space for collaboration, and there are a lot of resources to share, how to guidelines of how to prioritize the recommendations following the self-evaluation, and many other toolkit. This self-evaluation toolkit will be available with all the materials to carry this effectively. You will be invited to participate in formative webinars to guide and support throughout the process. We will acknowledge those hospitals that are in the hospital teams that are in the hospitals participating in any publication that eventually may come up of the scaled process of the safest. You will get a certificate of participation, an official proof of your involvement in this European Patient Safety Initiative, which is not, as I said, any kind of accreditation. And you will have available this personalized benchmarking analysis of your situation. The safest platform is, and all the materials are translated into different languages, being the Portuguese one of them. And we have the self-evaluation, the standards manual, all the kind of Excels to perform the observations, the different instructions and tutorial through the platform. And it is meant to be performed within a core team of professionals that would include an anesthesiology, a nurse, a surgeon, a quality improvement officer, a patient, an IT specialist, and some other hospitalist, and so on, and eventually having contact with other professionals per area in 5 days. There is an agenda to perform the self-evaluation in 5 days, always depending on if you prefer to do it in the full-time 5 days or extend it into taking some time here and there. It can be longer. There is no rush, but it's nice to have it be scheduled in as shorter as possible. And then what is needed from you at this stage is just to sign this interest form that I presented earlier, and then you will go into an informative webinar that will be summoned. Now, coming back from the European summer that we are having, we will have following. We will invite to these webinars to those that are interested. And as a third step, following this webinar, you will be invited to sign a letter of commitment of the institution participation and an active engagement into the self-evaluation, and then enroll in the patient and the safest platform. So you will have access to these tools, resources, and you will have a formative webinar, or the first formative webinar of a series of webinars to help you perform the self-evaluation of the situation in your hospital. So this is it. I would like you to
Well, thank you so much, Dr. Arnal, for being here with us today, for giving this inspiring lecture about the safest project. I think I can talk also regarding Gustavo, that we both are great and huge fans of your work. And we love to hear how you are passionate about patient safety. And here in Brazil, we have lots to do regarding this concept. And we do want to know more about this initiative and how maybe can we join it. So please, Gustavo, I'd like to pass the
word. Okay. Once again, thank you, Daniel, for your. It's a huge pleasure, and we are really big fans of all your work. I would say I would like to ask you, what were the greatest obstacles that you had with the hospital's participants? Because here I start talking to one of my hospitals where I work. And sometimes it's kind of hard to them to explain and to make them accept all that project. What were the obstacles that you had over there?
Thank you, Gustavo. Thank you, Claudia. Very kind words, and very happy to participate in this meeting. Well, the truth is that we do have some barriers when we do any activity related to patient safety, which is mainly the difficulty to secure the time from the first line providers to participate. But what we did in this case was approaching to the manager of the hospital and the medical director, explaining well the project, showing the potential beneficial aspects of it, of being part of an international project, a general self-evaluation on patient safety, to take actions later on. And we got the support from leadership, and that support was then distributed to the head of departments and made things easier. Not as we would always love to, of course, but much easier because we had time for the teams that were multidisciplinary to meet together, sometimes online, sometimes face to face, and take the time to make the self-evaluation. It was not that much time. It is meant to be performed in 5 days. I have to say, the hospitals I coordinated in Spain, they decided not to do them like full time in 5 days. They decided to distribute along a month the self-evaluation, and so that they had time to adapt. But the truth is that it was also they were piloting, so they were really the first to do the self-evaluation, and it was very nice to see how surgeons, anesthesiologists, nurses, but all the rest of the participants, most especially having the patients on board, one patient representative with his or her insights was very fruitful, because they would take another vision, focus more on the communication between doctors and patients about the shared decision and the information that they were receiving to take proper decisions together with the doctors. And that provided us a very nice insight of it. So having that was very good. Again, there have always been tensions, because theaters have to run, all the lists need to be performed, and still there is always, if there is commitment from leadership, it can go down also to the participants.
Thank you.
Let me ask you something, Daniel. In Brazil, we do not have a culture of benchmarking, and we do not have any database to do some benchmarking. So people are a little bit afraid of that. How can we engage the hospitals and also the anesthesiologists to take part in such a comparative initiative aiming to improve patient safety?
The truth is that no hospital will really be able to compare to your neighboring hospital. You will be seeing your situation in comparison with the rest of anonymous hospitals of your country or your region or the whole safest project. So there is no risk of being pointed as the one that is lacking some strategies for patient safety. Also, the comparisons will always be based on trust. So whether if your hospital is very strict on the self-evaluation, you may get lower results than other hospital that has the same implementation of the safety strategies than you, but they may do a lighter self-evaluation. So it's not like an accreditation when you have somebody coming from outside to survey what's going on. So the benchmarking is not the goal for the safest. The goal for the safest is to make to put your hospital, your center into a mirror and see where can I start working for patient safety. And you don't have to do it alone. You do it in a network, you see how others do, and you can take the more informed decisions based on that. But it's not really a mean to make a kind of scoring system for hospitals. Not at all. Not at this stage, at least.
Yeah. I guess Claudia was a point, a very important aspect of that, because there's no comparison. In this subject, do you think the 10 hospitals that are participating right now in the safest project in Europe, they can be an excellence hospitals, so can be some bias? And do you think here in Brazil, we can have the same problem as Brazil is a huge country. We have lots of realities. So sometimes 10, 15, 20 hospitals are deciding to participate, but they can be some excellent hospitals.
Well, that kind of bias will always be potentially there. Of course, hospitals that have some work on patient safety, have more safety culture in the organization, will be prompt to say, hey, I want to be there, because they also acknowledge that it is a never-ending story. There is always some improvement to perform. So that can happen, and it may have happened in some hospitals of the 10 that we did the piloting. But being this said, in every hospitals there were found nice areas of improvement, and this was something that was a learning point as well, that even those hospitals, even if they have been pre-selected because they have more interest on patient safety, it will be interesting for them. And then they will be those who start rolling the snowball, so that the project will grow bigger.
Great. Well, you made yourself clear that the safest project is not an accreditation, but as we do not have anything similar in Brazil, probably maybe people will think, oh, accreditations are very costly here. We have a huge cost, especially in the international accreditations. Is there any direct cost involved with the safest project?
For this stage, there is not. The project will last until the end of May 2026, and this is supported by the grant that we had from the European Commission. So there will be not direct cost apart from the time from the professionals spent in the self-evaluation. All the webinars, all the support to learn how to do, and even the materials available will be free of charge right now. The project itself, the consortium, is running right now a discussion about what will happen after May 2026. This has been an enormous effort, and we want to find different kind of partners that would be happy to participate with us to make this a continuation in the future. We are searching for grants. We are talking to different national societies, administrations, and even industry partners to see if they would be happy to make this a potential continuation. The website will be always open, and we will continue. But all the support from the research team needs to be funded somehow, and that is something that an ongoing work that is happening right now. We have a year to get to some solution.
Great.
Well, this is a very important point for us, because I'm starting talking to the hospital, and they already asked me how much it's going to cost me. So this is very important to emphasize that.
Yeah,
And
absolutely.
yeah. Do you think we have your consent to show your presentation to the directions board? Because
Please
as
do.
that, it's going to be easier when we show already your slides, and if your talk, when you talk to the Brazilian hospitals, it's going to be easier. Do you have?
You have my permission for sure. Also, we are about to launch a kind of again a similar webinar as this from one of the partners from the Safest that is focused on the self-evaluation, and so that it can also get more. It can be used through a YouTube video. It can be used to be shared throughout the teams and management and so on. But yes, all our support for that.
Thank you
Great.
so much.
Well, unfortunately, we do not have more time. Daniel, thank you so much for being here with us. Gustavo, thank you so much. And if you would like to say a few words to people who are
Uh,
here.
Daniel, thanks so much for your disponibility to be here with us. Claudia, thank you. I think it was a really great webinar, and we're looking forward to see you again in the next talks or maybe here in Brazil.
I would
It will
love
be a
to.
pleasure.
Thank you so much.
Thank you, Claudia.